So I'm really happy to be joined now by Dr. Mike Mack. Mike is well known to many of you, but Mike's played a key role not only in cardiac surgery, but in really a real team merger of cardiac surgery and cardiology. Mike, thanks so much for joining me.
Oh, thanks for having me, Randy. It's a pleasure.
So the question I want to start with is that I'm sure that many of the viewers are going to know what the Coapt Trial is, but what is the Coapt Trial?
So the Coapt Trial is a randomized trial of the mitral clip versus best medical therapy in patients with functional mitral regurgitation.
Okay. And is it, where is it in its launch? What's the status of it?
So the trial has been about a year in terms of ramping it up, going through the FDA, getting approval for the study, getting through IRBs, et cetera, and there are now 26 sites that have been activated out of 75 planned in the U.S. But we knew it was going to be a tough trial to enroll to begin with, and indeed that has proven to be the case. So I think we've enrolled 3 randomized patients in the first 4 months of the trial. Now there were only a few sites up and going during that period of time, but we've got about 20 or 30 screen failures for various reasons because of it. Yeah.
What's the ideal patient to enter this trial?
So the ideal patient is a New York Heart Association functional class 3 or walking class 4.
Okay.
They have to be on optimal medical therapy, and there's a central eligibility committee of heart failure specialists that determines that these patients really are on optimal medical therapy, which includes resynchronization therapy if appropriate. And have moderate or severe mitral regurgitation, and also have the mitral regurgitation at the A2-P2 scallop and a sufficient coaptation length that the clip can work.
So you're really honing in. I mean, it's really, start with a big pool and you're coming in tighter and tighter and tighter, aren't you?
Yeah, absolutely. And we also didn't want extremely end-stage disease also.
Right.
And so ejection fraction less than 20% is out, end systolic diameter greater than 60 is out, so the extremely dilated end-stage ventricles, probably this isn't going to work.
So it's a tough, the slowness is really the toughness of the entry criteria, isn't it?
Well, the other thing is that it's a high-risk trial. So it's high-risk patients that aren't candidates for surgery. There's been a lot of discussion of what the standard of care of these patients are. Is it surgery or is it medical therapy? And I think for the most part in these patients, it's medical therapy. It's not surgery. But we are limited right now to patients who are too high risk for surgery. There were a lot of us that felt that the trial should be an all-comer trial.
Right,
that it should be severe functional mitral regurgitation independent of risk. That was my feeling from the start, but for reasons we aren't there yet.
But I think it's a very important trial, so I wasn't trying to downplay that when I said the slowness. I mean, it really is a tough entry criteria. Mike, you had the pleasure of going before the FDA recently on data about the mitral clip. What was the outcome of that?
So the outcome of the FDA expert panel was a vote for the mitral clip. So the recommendation of the panel was to approve the mitral clip. Now, it was a mixed verdict, but came down on the side of recommending approval. So there are three things that the panel votes on: safety, effectiveness, and risk-benefit ratio.
Okay.
So they voted 8-0 that it was safe.
Okay.
They voted against it being effective.
Okay.
And they voted risk-benefit ratio, I believe it was 5-3, in favor of favoring the device. So the recommendation was to approve it.
And what does that mean? How does that translate when you say approve it? What's that?
So what happens now is that the FDA uses an expert panel simply as a panel of experts. And they can take their recommendation or not. Ultimately, approval is up to the FDA. It's not up to a panel.
Okay.
Now, the majority of the time, but by no means all of the time, does the FDA listen to the panel. So they can agree with the panel's recommendation, they can disagree, or they can come out somewhere in between. And maybe that would be a scenario that we would come out with here. That you could one of the possible scenarios is you could see a approval for a very narrow labeled indication.
Right. Mike, we could say this is very interesting, not only the process, but the whole attacking this clinical problem. Let me ask you, you've been, when you were president of the SDS and before, you were very active in a collegial professional relationship with interventional cardiologists and the whole transcatheter aortic. And then you really pioneered, along with David Holmes, this whole concept of the team and all that. Let's stand back from the aortic valve for a minute. Where do you see us going in transcatheter therapies for the mitral or the tricuspid valve?
Well, let me kind of start with the heart team to begin with, and although David Holmes and I made a great team together, the idea didn't originate with us. So
right.
the idea, at least in modern times, came from Patrick Sarice and Fred Moore, who were the principal investigators of the Syntax trial. And they put this heart team together to execute the Syntax trial, and we were members of that steering committee, and that's how I got to know David, and we spent 5 years in many hotel rooms together figuring out, with the steering committee,
right.
figuring out the trial. And then we just happened to be president of ACC and STS together. So it was kind of serendipity in a way, and the rest is history.
Where are we going if you look down the line? So I want you to, what's exciting to you as we look toward transcatheter therapies for mitral or tricuspid disease?
So I made a wrong prediction on the front end. I thought the mitral area was going to go much more rapidly than the aortic for a couple reasons.
Really?
One is there's such a huge unmet need, and the people with mitral regurgitation in need of repair is much greater than aortic stenosis. And number two, the failure mode is much less. So in other words, if the device didn't work, you just continue to have heart failure.
Right.
Whereas in aortic stenosis, you die. So I thought back 12 years ago now that the mitral was going to go first, and I was totally wrong about that. It's been a much longer road on the mitral for a whole host of reasons, including the fact that you don't have just one disease, the complexity of the valve, the anchoring mechanisms associated with it, the delivery, the proof of efficacy. So it's a very, very complex space. I'm very concerned that a lot of the repair technologies are having trouble getting there, because if you think what we do in surgery, we don't repair one thing. We do multiple things to repair.
To the mitral valve.
To the mitral valve. And I think that there is significant progress getting made in transcatheter mitral valve replacement. And so that is leveraged some off the experience with the aortic. So I am getting more and more bullish on the possibility of clinical success with transcatheter mitral valve replacement.
And so final question then, if you looked out 5-10 years from now, do you think transcatheter replacement and some form of repair may be a small portion or a sizable portion of mitral valve procedures?
So I don't know the answer to that, but I know how we're going to get the answer to that. And I think that there's two trials. One is the Coapt trial that's going to tell us. So the real clinical unmet need is in functional mitral regurgitation and heart failure. So let's start with that. The Coapt trial will go a long way toward telling us whether interrupting the cycle of mitral regurgitation begets ventricular dilatation and the vicious circle, whether interrupting that works or not. We also have just completed enrollment in the CTSN trial in ischemic mitral regurgitation of repair versus replacement. And if replacement is as good, or maybe even better than repair in ischemic MR, then that also is going to give legs to the transcatheter mitral valve replacement market. So I think hard to predict where we're going to be in 5 years from that. I think it will still be a minority just because of the amount of time it takes to get trials done, enrolled, and meet the endpoints, and then go through all the regulatory reimbursement process. So I think in 5 years it's still going to be a minority, but I think we'll be a lot farther ahead than we are today.
Super. Listen, you've done a great job. I mean, you really compliment you in being not only an innovative surgeon, but really good at working with societies and pushing the field forward, and I appreciate that. So thanks very much for visiting with us. Good to see you, Mike.
Thank you for asking me to do this.
Thank you. Thanks.
Pleasure.